Start recording. Slideshow. Good evening, everyone. This is Dr. SANGAM Gupta, Junior Resident, PGY2 in the Department of Radiodiagnosis, PMT Loni, Pravra Medical College. Today I will be presenting paper on MRI evaluation of different types of cerebral metastasis. Introduction. Cerebral metastases are the most common intracranial neoplasms in the adults, occurring in 15 to 40% of patients with cancer. Most common 5 primary tumors that account for brain metastasis includes lung cancer, renal cell carcinoma, breast cancer, melanoma, and colorectal cancer. MRI play a pivotal role in evaluating cerebral metastasis, providing insights into the lesion morphology, enhancing pattern, perilesional edema, and hemorrhagic or necrotic changes. Different primary malignancies exhibit distinct neuroimaging features which can aid in narrowing the differential diagnosis. This study aims to systematically evaluate MRI findings in various types of cerebral metastasis and correlate them with their primary tumor origins. By identifying imaging characteristics specific to different malignancies, we seek to enhance diagnostic accuracy and improve patient management strategies. Aim and objective of the study was to evaluate the MRI characteristic of various types of cerebral metastasis and correlate their imaging features with the primary tumor type. Method. Study design was retrospective descriptive case series. Study population was the patients with histopathologically or PET-CT confirmed primary malignancies and radiologically diagnosed cerebral metastasis. Inclusion criteria. Total 6 patients who underwent brain MRI for suspected or confirmed metastasis. Exclusion criteria was the patient with incomplete imaging data or significant motion artifacts. Case 1 is a 46-year-old male smoker with a slurring of speech since 1 day. Primary malignancy was CA lung in this patient and type of brain metastasis was cystic metastasis. So on T2 weighted images, there was a heterogeneously hyperintense lesion in the left frontotemporal-parietal lobe. There was on contrast, delayed contrast study, there was a ring enhancing lesion with central non-enhancing areas, and on flare study there was a disproportionate perilesional edema. There was a disproportionate perilesional edema. We can also see the ring enhancing lesions in the anterior temporal lobe in this slide. The lesion is causing the midline shift and also causing the mass effect here, compressing the ventricles. On follow-up, the chest X-ray was done. Solitary mass in left upper and middle zone of left lung was noted. Whole body PET-CT reveals the heterogeneously enhancing well-defined soft tissue density lesion involving apico-posterior and anterior segment of left upper lobe. So, history of metabolically active primary malignancy. So, the primary malignancy here was lung, CA lung. CT lung biopsy was done, which revealed non-small cell lung cancer. Case 2 is a 70-year-old male with the left-sided weakness since 3 days. Primary CA lung. Type of brain metastasis here is hemorrhagic mets. On contrast image, we can see multiple nodular and peripheral rim enhancement lesion we can see here in left parietal lobe, left occipital lobe, and also in the frontal lobes we can see multiple round to oval varying size ring enhancing lesions on contrast study. This is the hemorrhagic mets which shows blooming on the sweep susceptibility weighted imaging. We can see here in left cerebellar hemisphere, also in the right parietal lobe we can see the blooming. Also in flare there is a perilesional edema in right front of parietal lobar region, and on sweep obviously it's a hemorrhagic mets, so I have added many images of hemorrhages here. So this was the second type of cerebral mets, which is a hemorrhagic mets. On MR spectro, obviously there was a choline peak at 3.2 ppm and abnormal elevated choline creat ratio. Follow-up, the whole body PET-CT reveals heterogeneously enhancing well-defined soft tissue density lesion involving posterior segments of left lower lobe, suggestive of metabolically active primary malignancy. CT-guided biopsy reveals small cell lung cancer. So here the primary was small cell lung cancer. Case 3, 70-year-old male operated for left parotid Warthin's tumor, came with a new onset headache since 15 days. Primary here is Warthin's tumor. Type of brain metastasis is solid. T2 shows heterogeneously hyperintense lesion in right capsuloganglionic region. Also the flare reveals very extensive perilesional edema here involving right frontoparieto-temporal lobes. On diffusion, there was a peripheral diffusion restriction. On post-contrast study, the lesion shows in the right capsuloganglionic region shows the peripheral enhancement, and Also, the lesion, actually the post-contrast study images are not available due to some issues, but I have added other images sequences here for this case. The case 4, 65-year-old female with endometrial cancer and weakness in all limbs. Primary either is C endometrium and type of brain metastasis solid with hemorrhagic and cystic component. On a contrast study, we have patchy peripheral enhancement noted here on sagittal view, and which is just parafalcine location was there for this, also showing very peripheral patchy enhancement. T2 flare shows heterogeneously hyperintense with surrounding perilesional edema on flare, and diffusion and ADC, we had peripheral and patchy diffusion restriction on diffusion images, and few areas of blooming was noted in right hyparietal region on SWIP, susceptibility imaging. So we have case 5, 71-year-old female with a known case of breast cancer, came with the complaints of headache and giddiness since 10 days. Primary here is CA-breast, type of brain metastasis solid and cystic. So on post-contrast study, we have heterogeneously enhancement of solid component and peripheral enhancement of cystic component. So there was a heterogeneous enhancement of solid component and peripheral enhancement of cystic component. This is a cystic component, this is a solid component here. Okay, so this was a solid cystic mets in a known case of CA breast. On a T2 flare, there was a heterogeneously hyperintense lesion with the minimal perilesional edema here, involving the left cerebellar hemisphere. On diffusion, solid component shows tiny area of diffusion restriction, and cystic component shows no diffusion restriction. As here you can see, cystic area shows no diffusion restriction. Solid cystic lesion left cerebellar hemisphere. MR spectroscopy shows colon peak at 3.2 ppm here. So the next case is 52-year-old female operated case of glioblastoma multiforme of right frontoparietotemporal region. Now came with the left-sided weakness since 4 days. Primary tumor here is glioblastoma multiforme and type of brain metastasis here is multifocal. On post-contrast delayed scan, we have heterogeneously enhancing residual mass lesion, which you can see in the right anterior temporal lobe, the residual lesion. Also on post-contrast study, we have multiple homogeneously enhancing and few peripherally enhancing with areas of necrosis. We can see multiple uh, lesions, which are obviously the multifocal mets of glioblastoma multiforme. Hemorrhagic, the discussion part, hemorrhagic brain metastases are more commonly associated with melanoma, renal cell carcinoma, and choriocarcinoma, while lung cancer can also cause hemorrhagic metastasis. Lung cancer, one case exhibited cystic metastasis with disproportionate perilesional edema, while another showed hemorrhagic metastasis with susceptibility to image blooming and elevated choline on MR spectroscopy, which suggests the vascular nature of the small cell lung cancer. Small cell lung cancer being very aggressive as compared to non-small cell lung cancer. Breast cancer showed a mixed solid cystic metastasis with heterogeneously enhancing and minimal edema, supporting its variable imaging patterns. Most metastases are either solid or cystic, but a mix of both in the same patient is less common. Endometrial cancer displayed solid hemorrhagic and cystic components, an usual combination for endometrial metastasis, necessitating the consideration in differential diagnosis. Warthin's tumor, a rare case of metastasis with extensive perilesional edema and a peripheral diffusion restriction, highlighting the possibility of malignant transformation. Glioblastoma multiforme, multifocal enhancing lesions with necrotic areas, reinforcing the challenge of distinguishing glioblastoma recurrence from the metastasis. Brain metastases from glioblastoma multiforme are extremely rare, unlike many other primary brain tumors. Glioblastoma multiforme almost never metastasize outside the central nervous system due to blood-brain barrier and the short survival of the patients. However, in rare cases, glioblastoma multiforme can spread within the central nervous system through leptomeningeal dissemination or along white matter tracts. Also, it can show drop metastasis. Here are my references. Thank you, all the faculty.